Hello? Whoa. Welcome back, everyone. We're going to get back on track. Welcome back. Refreshments, coffee, tea, scones. How are the scones? Okay, hello, everyone. As Platinum sponsor, we are very pleased to introduce the first keynote speaker of the conference, Dr. Thomas Ross. And I'll say, when we were asked, would we introduce someone, and we said, who could we introduce? And as soon as his name came up, I said, that's it. I'm going to introduce Dr. Ross. I've heard his presentations. He is a brilliant, compassionate, and really innovative speaker. Dr. Ross is a cognitive neuroscientist at the University of Geneva in Switzerland, and his background includes physics, neuroscience, and psychology. And he has had an interdisciplinary interest in treating brain disorders. And it goes much deeper as well. During his academic career, he has explored cognitive function and neuroplasticity using different windows on the brain, such as electroencephalography, transcranial magnetic stimulation, functional MRI, and PET, positron emission. I'll also mention that his work in the area of self-organized self-criticality in the brain is really excellent work and reinforces a lot of what we are doing clinically. Everything from QEEG, use of normative databases, and other things are supported by this concept of self-organization. Dr. Ross's goal is to continue investigating neurofeedback at the intersection of engineering and neuropsychology in order to contribute towards a safer, non-pharmacological treatment in psychiatry, neurology, and rehabilitation. Dr. Ross's keynote address is titled Homeostatic Normalization of Alpha Brain Rhythms within the Default Mode Network and Reduced Symptoms in Post-Traumatic Stress Disorder, following a randomized, controlled trial of EEG neurofeedback. And this talk will also be interpreted simultaneously into Spanish. So without any further, I will allow Dr. Thomas Ross to address you as the first keynote speaker.
Thank you so much for the kind words. It's my pleasure to be with you and present our recent results. Thank you very much for the invitation. And I realized the title that you read out was a bit of a mouthful and maybe a bit too technical, so I've summarized it in a shorter title here, just to get an idea of what we're talking about, which is about actually restoring alpha rhythms, which I think most people in the neurofeedback field will be very familiar with, in PTSD. So it's simply about regulating alpha rhythms and restoring them, and we'll find out why it's important to restore them and regulate them, hopefully. So I realize it's lunchtime there, and I hope I won't keep you too long from your dinner. So I will try to do a concise presentation, but nevertheless I want to take you on a bit of a journey about how we ended up where we ended up in terms of this clinical trial, and how, you know, it's a kind of a scientific journey. Also, it's interesting from the point of view of how things might evolve in science, how not everything is, you know, clear from the outset. So I hope you will enjoy that. And I want to start with just the first kind of approach that we used that was a little bit different from the norm that is already in the literature. I know some of you will probably be familiar with the Peniston-Kolkowski studies for PTSD that were, you know, pioneering in the approach that they were actually enhancing alpha rhythms directly, and they found some beneficial effects there in veterans with PTSD. But we wanted to take a more kind of like start a little bit from scratch and ask, okay, are there any other ways we could do this, and see, you know, maybe there's a different approach that might also work. And we were kind of starting with the basis of the actual cognitive or behavioral performance. And when I actually started this first study, which was in collaboration with Ruth Lanius, Professor Lanius in Western University in London, Ontario, we spoke about how we could try to improve the sort of cognitive symptoms of people who have PTSD, namely kind of their inattention and mind wandering, which they struggle with a lot. So the first idea was to kind of see whether we could come up with a neurofeedback protocol that might kind of be used to reduce, in fact, this inattention, or reduce also the mind wandering. And actually, we started with a study first in healthy control subjects to see how that validates in terms of the neurophysiology, and then we wanted to move to the PTSD patients in the second step. But the basis of that first study, which was a long time ago already, maybe 10 years now, in 2013, we published the data. I started there in 2011, and we had the idea of how to leverage this kind of neuroscientific idea, that some data that link the alpha rhythm to attention. And as you know, alpha is usually inversely linked to visual attention or sensory attention in general. And you can see here in the top plot, when people, healthy people, pay attention to visual stimuli, then during the actual processing of these stimuli, these alpha band as well as the low beta band decrease in power, especially in these posterior kind of occipital areas, and the actual gamma rhythms that are usually unseen by classical EEG, that's more than 64 hertz, the high gamma usually increases. So that's the typical pattern of activation of the sensory cortex, the visual cortex, when one is attending to stimuli. And you can see here clearly that this alpha rhythm kind of decreases kind of in those areas. So that was a starting point. Okay, well, if they are paying attention to something visual stimuli, usually the inverse state of mind is that one is quiet internally and one isn't kind of thinking a lot. So there have been a lot of studies implicating also mind wandering with attention, and usually it's been shown also in meditation literature that one is focally attentive to something, mind wandering decreases. So basically, you can imagine that sort of the alpha rhythm acts a little bit like a gate for visual information, sensory information. So when this gate is up, i.e. the alpha is up, then the visual information is not coming through, the sensory information is coming through, and that kind of protects the brain from these external influences, external stimuli, and that allows the brain to kind of internally mentate, to mind wander, think, and go through the little thoughts about itself. And that's exemplified here by this figure here, where, for example, the alpha amplitude fluctuates, as you can see here. And when the alpha amplitude is high, this would we would consider an internally oriented state. And then, at other times during particular brain states, you would have alpha would be lower when you would be attending to something in the outside, whether in the visual cortex, when you're looking at visual stuff, or if you're attending to kind of auditory stimuli, then the alpha rhythm in the auditory cortex will also decrease, and so on, so on and so forth. So these things are kind of constantly fluctuating on a sub-second scale. But the idea was to see whether we could, try to decrease this internally oriented state, and vice versa, increase this externally oriented state, right? And if you then put the alpha rhythm as a kind of average rhythm, average value of this alpha rhythm for each subject, then you can make a kind of a middle ground where you could say, okay, above the average value, this is what we consider internally oriented states, and below the average value of the alpha resting state, that's kind of considered an attentive state. And that's exactly what we trained. So we asked people to keep their alpha activity below the resting state value of the patient, of the person, and it's not patient, they're healthy controls, and that would basically give a 50% negative feedback at the beginning, and then after that, that would raise to something 60, 70, 80% positive feedback. So that was the idea, and that's the protocol here illustrated here, which is reducing alpha power at electric PZ, which is usually maximal. And we had two groups, which was the first was the real neurofeedback group, where we provided real-time neurofeedback based on the alpha power. And on the other hand, we had a sham neurofeedback group, which is kind of a yoked design where we replayed somebody else's EEG, which wasn't contingent on the real brain activity of the person controlling. So they were under the impression they were controlling real EEG, but it was actually just a fake signal. So that was the control condition we used. And of course, you're all familiar with neurofeedback. So here's the closed loop. we take the EEG signal from the PZ sensor. In this case, we extract the alpha power, and that is then used to drive this video game, which is the EEG spectrum space race. And in fact, we had two spaceships flanking the main one. So in this case here, when the alpha was low, the spaceship would move forward. The middle one, that was the main feedback, and then the other two were just used for artifacts. So if the person moved a lot, they would create low frequency artifacts. So this spaceship would then move on the side, which was low frequencies, and on the other hand, the high frequency spaceship here would be for like EMG artifacts for muscle activity and so on. But the main feedback for the alpha signal was simply just the middle spaceship. And that's illustrated here again about what it looks like during these two different states, extreme states of high alpha power, where you can see the rhythm emerging here. And that would basically lead to this spaceship being stationary in the middle, which should correspond to these reduced attentive states, and low alpha power, which would be positive feedback, right? So I hope that's clear. And then on top of that, we also had some additional hypotheses regarding what might happen also using some other neuroimaging technique, which was the fMRI, functional MRI. And there's been some studies that have also implicated the alpha rhythm with mind wandering. So that's kind of coherent with the fact that it's linked to more inattentive states, but also that this mind wandering is linked to the default mode network. The default mode network is a specific network that has been identified 20 years ago, showing that it's a network that's related to internal processing of the self. So whenever one is internally meditating or planning different things, or having just general random thoughts, this network is usually active. And in fact, when we're tending to something on the outside, and the thoughts are less prominent, then this network is actually suppressed. And conversely, there's been simultaneous EEG fMRI studies elsewhere that show that the alpha rhythm is also positively correlated to the default mode network. So that makes sense that then the alpha rhythm is kind of positively correlated to the mind wandering as well as the default mode. So in fact, the idea overall then is if you take all this information together, you would hypothesize that decreasing the alpha rhythm would decrease mind wandering as well as decrease the default mode network connectivity. So that's the idea here. That's this network here. They were indicated in red. And that's what we were aiming to decrease, hopefully down-regulate that also post-neurofeedback with neuroimaging, but not actually doing neurofeedback with MRI, of course. And this is the design of the study that we used. So obviously, EEG and fMRI usually don't go well together. It's kind of a little bit like oil and water because there's magnetic fields that interfere with the EEG in the fMRI. So what we did was actually we did an MRI scan just before the neurofeedback session that would involve an attention task where we actually probed for mind wandering. You can see all the details in this publication, so I won't get into too much detail about how that was assessed, but essentially we calculated how quickly they responded to some stimuli, as well as if they reported some self-report mind wandering, degrees of mind wandering. And then after they came out of the scanner, we would put on the EEG cap, and then we would do neurofeedback for 30 minutes based on the alpha rhythm on PZ, decreasing this alpha rhythm, and then we would take off the EEG cap, and then they would go back into the scanner and do exactly the same task. And then we compare pre to post neurofeedback, is there any modulation? So the innovative, I think, part of this study was that we didn't do it across multiple EEG session, neurofeedback sessions, but we just used one session. We tried to look at, is there any modulation in the EEG as well as the MRI, as well as the behavior, just if that was possible within one session of neurofeedback. And what we first found was that actually the neurofeedback was successful compared to sham, so that the decrease in alpha was more prominent, and the stronger desynchronization of alpha around this minimum PZ. So statistically, the effect was much larger for the neurofeedback group compared to the sham group. Plus, there were some topographical differences in the beta band that makes us think that the sham group was also doing something, but it wasn't really the protocol that was overlapping too much with the alpha, at least not as strongly. So we were hoping that we would find some differences in the neural substrates also that were modulated between the two groups, long term after neurofeedback. And so what we first found the x-axis, this is the change during training, normalized by the baseline value, so it's a percent change. So the good performance you can consider as the ones that have more negative percent values. So this is a decrease of 20% in the alpha power, and then 40%, 60%, and 80%. And then different dots are each actual participant, and the colors are different parts of the electrodes of the scalp, although the neurofeedback was only provided the parietal electrodes. But you can see in general, most electrodes decreased alpha, firstly, and there's some variance in how well different people performed. But what is also interesting is that if you correlate, when we correlate that with the resting alpha change, that means pre to post neurofeedback, there's actually positive correlation. That means those subjects that decreased alpha mostly during neurofeedback translated that change also into the post neurofeedback resting state. So that's some evidence to show that there's some plasticity there, even in a 30-minute session of neurofeedback using this protocol. Now, that was not actually the case for the sham group, which is reassuring. So although the sham group did demonstrate some changes in alpha during the session, as you can see here during training, at the training session, these changes were a little bit more dispersed less dispersed actually over the x-axis, but even more importantly, there was no correlation with the actual changes in the spontaneous activity post neurofeedback. So therefore, those two domains were not coupled in some sense. So whatever happened during this training session didn't really translate into change in the spontaneous resting state activity post neurofeedback. So that shows to me that there's some really nice evidence there that neurofeedback actually does work, at least for this protocol, within even one session of training. Secondly, what we also found is when we correlated these changes in mind wandering pre to post that neurofeedback session, again, there's a percent change here. Positive changes mean increased mind wandering here on the y-axis, or negative changes mean decreased mind wandering. We found that actually they were coupled to the pre to post resting state alpha changes we would have hypothesized. So decreased alpha post neurofeedback predicted decreased mind wandering post neurofeedback. So that means that people who had less alpha, they were like a little bit more sensory attentive, and that led to less mind wandering during the actual task at the second time when they were doing it in the scanner. And that was not actually the case for the sham group. So again, some evidence to show some causality there that neurofeedback induced a different kind of attentional state post neurofeedback compared to the sham group. And finally, since we had hypothesized also changes in this default mode network, which is critical to self-processing and mind wandering, we looked at the data in the MRI that was coincident with this task, and we found that actually this default mode network was actually correlated in the right direction with the behavioral and EEG changes. So firstly, as predicted by the literature, this default mode kind of node called the precuneus was positively correlated to increases in mind wandering. So inversely, decreases in connectivity of the precuneus would have been associated with decreases of mind wandering, which is what we kind of wanted. And also the same thing for the resting alpha change. So in this case, both of these kind of parameters, the EEG as well as the behavior, are linked to the same regions of interest. And that's also the case for the sham group. So I think overall, we're very excited about this because it has implications for decreasing mind wandering across a range of psychiatric disorders, like depression as well, where they have intrusive thoughts, and increasing attention, maybe in ADHD and so on. So, but with the caveat that this was a study done in healthy participants, and it fit in line with all the hypotheses. So in some sense, we decided, okay, we should go ahead and test the same approach, but now in patients with PTSD. So essentially, we translated exactly the same design in patients with PTSD. So you can see here the protocol is exactly the same. In this case, for ethical reasons, we didn't run a sham control group because we didn't feel it was fair to put them through something that we didn't expect to have a therapeutic effect. So we had only the PTSD patients, only because we had validated that already with the other design. And we gave them one single session of 30 minutes of neurofeedback. And what we found, much to our dismay, let's say, at least at the beginning, was the positive was that they were able to decrease alpha. So you can see here T1, this is the resting state before training, was this value here, and then they were decreasing the alpha. So they did have control over the alpha, and they were able to decrease it with using usually focal attention. But and paradoxically, this alpha actually increased post-neurofeedback on the group level. So this is what we were not expecting, because according to neurofeedback models, the direction of training, the training should lead to changes in plasticity in the direction of training, right? And we didn't find these positive correlations between resting state change and training alpha change. So we scratched our heads for a while around this phenomenon, because it was completely not in line with what we found in the other study. And then we started to dig a little bit deeper, and we found also that since we administered some questionnaires, clinical questionnaires before and after the neurofeedback one session, we also looked at how much these patients felt they had symptoms of PTSD, but especially the symptoms of arousal, hyperarousal, tension, nervousness, the kind of discomfort they felt before the session and after that one session neurofeedback. And in fact, we found that the more the alpha increased after neurofeedback, the more that their arousal decreased. So the better they felt. In fact, they described some of those that had very large changes in decreases in arousal. They described states of euphoria and calm and so on. And so we were really puzzled, because we thought that decreased alpha power would be more beneficial for them rather than an increase of alpha, right? Based on this mind wandering and cognition and so on. So that was again, like, very puzzling for us. But you know, serendipity has its own ways in many times. So what we then looked at is we sampled finally 2 or 3 years later another control group that was matched for age and sex and everything, and socioeconomic status for this PTSD group. And we found that actually at the beginning, the PTSD group that we tested was actually significantly lower in alpha power compared to the control group. So this is before the neurofeedback, and T2 here is after neurofeedback. And what you can see here is that this change in alpha that increases alpha is actually moving this population towards the normal levels. And so it makes sense that they would maybe feel better if they were going more towards the mean rather than away from the mean. So although they did go away from the mean during the training, then this kind of paradoxical rebound, plastic rebound in the system led them to go towards the mean. And so it's a little bit like a cork that you push down on the water, and the more you push it down, it pops back up. But this was basically an effect that was specific to the PTSD group that we didn't find in the control group. So we were asking ourselves, why is it only happening in this population? And we kind of got an inkling of an answer, because these patients were actually abnormal at baseline compared to controls, and where the controls were actually much higher in alpha. So in some sense, perhaps it is the fact that they were too low in alpha to begin with, and then squeezing it further triggered this response to actually increase it much higher later on. So that was the hypothesis. And actually, this difference at baseline was confirmed by other studies by independent groups. For example, this study here by Clancy et al. In Brain Journal, they found that PTSD patients, as you can see here, this red line, have significantly lower relative alpha power compared to both controls here, the black line, as well as the general anxiety disorder. So it seems to be quite a replicable signature of patients with PTSD. Perhaps not every patient, but on the group level, this is a very solid finding that has been now found across multiple studies that seems to hold, where this decreased alpha power seems to be abnormally low in patients with PTSD. And even those patients that suffer from anxiety that you would expect maybe they would have too much sort of attention or something to the outside, they don't display as much as a desynchronization as the PTSDs. Now, how do you interpret that clinically, this decreased alpha power? Now, what I haven't told you is that alpha power is also linked to metabolic activation. And so there's one study or a few studies that have implicated alpha also to metabolic activation, but inversely. So I show you here that they had a few lectures here, and they looked at the MRI signal, fMRI signal on these points, and they found actually that when the fMRI signal activates, i.e., those blobs that you see in neuroimaging papers, the alpha is usually actually lower, than the normal. So it has a negative correlation. So as the bulb activates, the fMRI activates, the region of the cortex activates, the alpha, theta, and beta bands usually decrease, particularly in these temporal and occipital areas. So these so-called low frequencies, and conversely, these positive correlations with gamma rhythms that are much higher frequency. So that's kind of in line with the attention results that I showed you before, where the alpha decreases and the gamma increases during attentive state. So in some sense, attention increases the metabolic activation of that cerebral region, and that leads to this kind of EEG signature, where the whole EEG kind of moves to faster frequencies. And these low frequencies are less dominant, especially in alpha and sensory areas. So that would imply that actually in PTSD, since they actually exhibit low alpha power, that in some sense the cortex is kind of continuously hyperactive, let's say, at baseline, because it has very low alpha power, or hyperaroused, let's say. So the metabolic expenditure of the cortex on the whole is actually very high in PTSD, and perhaps that makes sense because they are also behaviorally aroused in terms of their symptoms. And in fact, this paper from 2020 implicated exactly that, where they looked at cross-sectional data, looking at how much alpha power these patients had and how much hypervigilance they also displayed. And these regions using Loretta were found to mostly negatively correlate with hypervigilance. So lower alpha increased hypervigilance. And particularly if you look at these regions, you might remember that these are actually the nodes of the default mode network that I was talking to you about before, that I mentioned. So all of this data now seems to kind of come together in some way. And it's in line with our results that increased alpha power in these patients actually leads to lower arousal, because you're kind of normalizing that baseline level towards normal population levels where arousal should be more balanced, for example. Okay. And how can we explain this normalization? I mean, what are the models that exist in neuroscience currently that may be consistent with something this, let's say, strange, that actually is not very common either in your feedback from what I know, but also in neuroscience in general. There are studies that have looked at different types of plasticity, but they're usually molecular studies in animals and so on. There are some TMS studies that have shown homeostatic plasticity effects. So what I mean by the word homeostatic is a second type of plasticity, which is almost the opposite of the traditional one that we're familiar with in general, which is the Hebbian one. The Hebbian one simply is the one that is linked to correlative activity. So, which is also a kind of associative plasticity. That means that if you train the circuit in a certain direction, then you expect that circuit to hold in that direction afterwards, right? So you kind of make an imprint, and the configuration that you drive it at, or the activity that you drive it at, is then kind of generalizes further outside of training session. So that's familiar from the usual neurofeedback paradigms that we know. For example, if we train alpha up, alpha stays higher later on, or if we train SMR up, then the SMR is higher, or we train theta down, then theta is lower, and so on. So it's in the direction of training. The plasticity occurs in the direction of training. And so that's the usual model that we use for QEEG informed neurofeedback, for example. But in this case, we can also consider using homeostatic plasticity where, in fact, the change is in the opposite direction of training, which is exactly what we observed. So we decreased alpha power, but we found an increase in alpha power post-neurofeedback. And how can this be explained? So just to go through the basic Hebbian model, where you have some receptors and you drive the activity here, and then these receptors upregulate, and essentially you're providing the system with positive feedback. So it starts off at a particular level, you're moving it towards a higher level, let's say increased activity, and then because there's this positive feedback loop, then this activity is maintained post training, right? So that's what we're most familiar with in terms of plasticity. But there is this other type, that is actually maybe not explored enough or appreciated, which is the homeostatic type. And why does this exist? So in this case, you have some activity, but this activity occurs in a particular, at the beginning, it occurs in a particular dynamic range. And then if you exceed that dynamic range, then the system uses negative feedback to bring the activity back into that optimal dynamic range, right? So let's say the PTSDs are here at the bottom of this dynamic range. They already have very low alpha power. And then you're bringing them to go even further down. Well, the system is not going to allow that for too long. And it will then bring back, in terms of negative feedback, back into the form. The interesting thing is that it doesn't bring it back to the initial level, where it was kind of, let's say, pathological, but brings it back further. So there's an overshoot towards even more, let's say, optimal level that is displayed by the normal population. So the actual perturbing of the system in the opposite direction then triggers the system to normalize back to the levels that are actually more healthy and that are therapeutic. So the reason why the system might want to do that is, of course, because you cannot maintain levels of happy and plasticity ad infinitum. You cannot say, well, I'm going to keep raising higher and higher activities or lower and lower activities, because there must be some kind of ceiling effect where these activities become pathological. So, for example, in epilepsy, you don't really want synchronization levels to exceed such high values where you actually train the whole brain to be in one rhythm. So these homeostatic mechanisms are to protect the brain from basically reaching their extremes. And so in the case of PTSD, since they're already at a very extreme value, the system somehow is, maladaptively got stuck there due to the trauma probably, and then didn't really know anymore where is the mean, and a little bit, that's why I say maladaptive, because it's not the fault of the system, but it's for somehow that actual traumatic events didn't allow the system to recover back to baseline. So they got a little bit trapped into that lower, let's say, dynamic range. And then if you use neurofeedback to perturb that dynamic range, then hopefully the system starts to come back up. And we know that PTSD is not a genetic problem. It's something that's acquired through experience. So in some sense, you can maybe restore these more optimal values for neurofeedback through neurofeedback that are beneficial for therapy. So that's the theoretical part done. And finally, I want to show you also that this default mode network that has been linked to the alpha that I've previously shown you has previously also been implicated by Ruth's group, Professor Lennis's group in PTSD, where they showed that actually the default mode network is actually disconnected in PTSD. So here, PTSD patients have reduced DMN connectivity compared to neurotypical controls. So probably I should have read some of her papers before we started that first study. But overall, it all seems to match the fact that increasing alpha power is beneficial for arousal, plus for restoring DMN activity in the MRI domain. The question was okay, since we had this single session effect, plus we didn't really have a control group, could we run a study that would contain both of those things and actually validate some of these effects of plasticity in the long term? So whether they generalize also outside of the neurofeedback training that lasts for longer than a simple day or so. And that's the trial that I will be finally talking about today. So here we're about halfway through the talk. This is a paper that we've published, a study that we published just recently in Brain Communications. The first author was Andrew Nicholson. It was a study that was conducted at Ruth Lennis's lab. I was co-senior author on the data analysis. And what they did was they basically randomized a group of PTSD patients that were 38 patients into two arms. It was a double-blind randomized controlled trial where one arm got neurofeedback for 20 sessions over 20 weeks with the same protocol of decreasing alpha power. And the other arm got a sham control group, sham control. So this was also PTSD patients, but they received only the sham signal. And otherwise, the design was pretty much the same. The neurofeedback was pretty much the same as of the other studies I mentioned. And also, they did a 3-month follow-up, which there was no intervening training in between to see whether there was a long-term effect on symptoms outside of the training kind of. And we also sampled the healthy control group of 32 neurotypical controls to compare these baseline values and see how these changes in brain rhythms occurred. So firstly, I just want to show that the actual neurofeedback was successful. This is something that's sometimes overlooked in a lot of clinical trials. They say they have, behavioral effects, but is there any data to back up that the neurofeedback actually was impacted these signals that we are actually trying to train? So you can see here that in the experimental group, that's the red line, the one is signifying the percent change relative to baseline. So lower than 1 means decreased relative alpha power. And here you can see the sham group pretty much maintain alpha power compared to the resting state of that session, or more, even increase, whereas the neurofeedback group do decrease it considerably, and then it slightly creeps up over time, but that could be maybe considered already the beginning of some kind of homeostatic increase. But at least during the neurofeedback session, they successfully decreased the alpha rhythm. And then across sessions, you can see they keep this alpha rhythm on average lower than the baseline average. So whereas the sham group is much more so the between session changes are also maintained with alpha being decreased. And the first thing we were happy to replicate was that in this other group of patients, so in the whole group of 38 patients, we again replicated this signature of reduced alpha relative power in patients versus controls. And in this case, since we had more electrodes, we were able to carry out inverse source localization using Loretta, and we found that these regions especially had lower alpha power. So you can see these are kind of also frontal regions as well as occipital regions. So not the whole cortex, but pretty much a large part of the cortex was implicated, especially the frontal areas, where significantly lower after statistical correction in alpha power. So that was nice that pretty much another study showed exactly the same signature of baseline EEG in PTSD. And then what was also positive was that when we looked at the changes pre to post neurofeedback treatment, this is in the resting state, that only the experimental group that received real neurofeedback had an increase in alpha power, and specifically in this kind of midline prefrontal cortex region here, that includes some of the BMN regions, the anterior nodes of the BMN. Whereas no changes in alpha power were found for the sham group. Okay, so that was in line with the hypothesis that there was going to be a rebound, but this study showed it in the first time that there is a rebound after at least 20 sessions of neurofeedback, and that this rebound is plastic because it wasn't immediately after one session neurofeedback. It was after 20 sessions, and there was a few days after the training had finished when we did this resting state EEG on these patients. And finally, if we overlap anatomically, at least these region where this alpha rebound occurred, it actually overlaps spatially with the regions that were abnormally low in alpha power at baseline. So in fact, there's anatomical specificity, but also frequency specificity for the alpha being the rhythm that is being restored in this prefrontal cortex, which overlaps with BMN regions. So that's nice because that's called the conjunction analysis. And that was not the case again for the sham group. And then finally, the icing on the cake was, of course, that there was improvement in clinical symptoms that was much higher for the neurofeedback group than for the sham group. And you can see here at pre-neurofeedback, this effect was around 0.7 clinically. There was still an effect for the sham group. They were receiving some type of psychoeducation, but this was not considered clinically relevant. And moreover, the neurofeedback group maintained this very large effect size improvement, clinical improvement at 3 months follow-up. So it makes us believe there's a long-term plasticity there. So that follow-up actually related to something like a 60% remission rate. So 60% of patients would not consider it anymore to have a diagnosis of PTSD. Also positive was that there were no patient dropouts, there were no abreactions to the treatment, even though we were decreasing the alpha power. Nobody dropped out of the treatment. There were no significant adverse effects. And this remission rate of 60% is comparable to the best current gold standard treatments for PTSD. The fact that it's actually non-pharmacological is, of course, the most important thing, and that it lasts post 3 months follow-up is also, I think, exceptional. So finally, I just want to thank all the collaborators of the study, namely Professor Leflenius and Andrew Nicholson, the first author of the study, and especially the study participants. So thank you very much for this opportunity, and I'll take any questions if you have any. Thank you.
Thank you so much. Follow the same protocol. If you have questions, you can come ask them at the mic right here.
Well, I'm not going to be shy if nobody else does. Thank you so much for your talk. I've been a little bit of a microphone hog so far, but I would like to ask you this question because what you're finding it correlates with what I was asking in the last session. You're seeing this highly reduced alpha activity in the posterior. And in my findings, what I see, and I would like to get your feedback, is I see it seems to start at T6 and theta, and then as the trauma increases, it recruits and it starts to recruit alpha and even beta. And so the power in the posterior overall goes down, and it does start to reflect the alpha overall can look like the lowest, but do you have any feedback? Because it's theta that I see show up primarily in that post-temporal region at T6. Can you make sense of that for me?
I will try. I mean, I don't have as much clinical experience as obviously you or any of the clinicians that work directly with the patients. I mean, I think for most of the clinical sort of anecdotal evidence, I think you would need to get in touch with Professor Lanius or her group who have worked directly with the patients in these sessions. But I can only say that the theta rhythm is one of the dominant rhythms of the temporal lobe. And so, although these findings are usually related to the frontal lobe and sort of occipital areas where we trained, or parallel areas, it is possible there are some other effects that are, let's say, concurrent at the same time in some of these more temporal areas, which of course are part of the limbic system and are involved with emotional processing and so on. So I think it's still very mysterious about what's happening to the other rhythms. I mean, I have looked at some theta rhythms. I think there's some supplementary data showing there's some changes in theta or delta also in these patients. But I can't recall anymore, is it in the direction of increase or decrease? But it's potentially also interesting maybe to target the theta rhythms also in this population. As I say, I think PTSD is rather heterogeneous as a psychiatric disorder. So I wouldn't say that alpha is the main marker that you will find. Decreased alpha is the main marker you'll find in every patient. So it could be a mixture of different signatures where alpha would be lower or theta would be higher and so on. I think that still needs to be explored to see, like, are there any classes of PTSD patients that demonstrate particular signatures and how these specific signatures might be related to symptoms like dissociation and so on. But yeah, there's no data at the moment on that.
Thank you. Your findings are very helpful. I really appreciate it. Thank you.
We have one question from Robert Crago online. Might training alpha down and up be even more efficacious to reestablish the homeostasis?
The question is, I don't know, because nobody is, or at least not in our group, we haven't tried to do both up and down at the same time. We know, of course, that with Peniston studies show that turning up also has a beneficial effect. I think the key question is, we could do a randomized control trial to compare the two approaches, and maybe add a third arm also to do both directions, like intermittently or something. But I would say that from the point of view of homeostasis and how I think that this homeostatic circuit is triggered to actually re-normalize the activity, you need to maintain the activity in this particular state for a long time. So if you want to induce this trigger to increase alpha, you would need to keep the alpha very low for a considerable amount of time for that to be triggered, right? Because you want to excite the system so much to pull it away. It's a little bit like if you have a cork again, and then if you don't press it down enough, it will not pop back up. So just popping it up and down all the time might not be the way that you'll get the maximal extension up. It's the same with the elastic band. If you don't stretch it enough, you won't get that force to make it stretch back, collapse back. So I think in terms of this theory of let's say self-tuning systems or homeostatic systems, I think the way you trigger that response is to really stretch the circuit as far as possible, and then it will hopefully snap back on its own. But again, we don't know, at least in our study, we haven't found any adverse effects, but potentially that with different rhythms in different directions, you might have maybe some adverse effects, like, I don't know. But so far we haven't seen that. So I don't know. I think it would have to be tested in a separate study, this idea of up and down. And of course, the thing that comes to mind is slow cortical potentials, where people train slow cortical potentials up and down and so on. So this might, again, increase this dynamic range, or in the end, get the system to go back to the mean levels. So it's not a inconceivable idea at all. I think it's an interesting idea to try.
So I have a question regarding the average of alpha for the group for PTSD was lower than norm, but were there outliers, and were any of the outliers actually having more alpha than the rest, or all of them were low? And then secondly, if there were outliers, did they respond to the training the same?
Mm-hmm. Great question. I think from what I remember looking at the scatter plots of how the distributions overlapped. And of course, if you had complete difference between the two distributions, so none of the patients would overlap with the distribution of the controls, then you would have an effect size of whatever z-score of 2, an effect size of 2, and then you could classify essentially just based on this marker. And of course, that's not the case. I think the effect size differentiating these two populations is still around 0.7 or 1, something like that, 1, I think. So overall, yes, it's an interesting biomarker. It's probably the best biomarker if it stands on its own, but there is a significant proportion of patients that will not be considered abnormal, or that would be classified as still normal based on their average baseline alpha. I think in this case, since you're looking at an effect size of 1, something like a 30% overlap. So there's still 30% or 40% of patients unaccounted for that do not display this abnormality, and that exactly might also explain why there's only 60% remission, because there's 40% unaccounted for there in terms of treatment effect. So clearly there's some heterogeneity there, and alpha isn't the only story or the full story. And there might be, as we previously discussed, theta and other circuits and networks that might be abnormal connectivity, who knows what. So I think we need bigger samples in PTSD patients to decipher this, and maybe implicate other rhythms like beta and so on. So I think this is just a starting point, but I think the study does demonstrate an interesting physiological insight into how the brain regulates itself, and how these spontaneous activities can actually tune themselves, which is really interesting, that even in a psychiatric disorder that we think does not know where to go in some sense, or at least people lose hope that they can treat their PTSD symptoms, that the brain can, find the new configuration. So that's in line with, the fact that feedback is used for psychiatric disorders. That's really reassuring and I would say promising.
Was there any evidence that training alpha down at PZ affected the periaqueductal gray?
I don't know the answer to that question because we did not, we only used EEG source imaging, right? So we will not be able to see the periaqueductal gray with that, that signal. I think maybe there's some work by Ruth that you can look at some of her publications that may have implicated the periaqueductal gray using MRI scans that they did pre to post neurofeedback. But at least in this clinical trial, we did not image the effects of the periaqueductal gray. So I don't know. So it remains to be seen.
The internet is a flurry. There was a question earlier. I'm going to restate it here. Its training was located in the posterior site, but the changes were recorded in frontal midline. Can we say this was training that included a network?
Yes, for sure. I think that's exactly what's interesting about this effect. So you have this rebound, which is interesting. So the effect is in the other direction, but also the anatomical region is not exactly the one trained. Although one can't really say that EZ is equivalent to the posterior default mode. But of course, a lot of these rhythms and regions are connected to other parts of the brain. So we know that the posterior part of the DMN that generates alpha rhythms is part of the DMN, and the DMN is connected to the anterior part of the DMN. So most probably, yes, that's how the other parts in the frontal lobe was also modulated. And what's interesting is that this frontal region was also the one that was most abnormal. So in some sense, the brain also found a way to normalize the anatomical regions that were most abnormal, whereas the other ones that were not so abnormal were not really modulated or were not homeostatically upregulated. So it looks like the places where things are wrong, maybe that's where the effects kind of flow towards due to this self-organization of the brain. So maybe we don't need the anatomical specificity of neurofeedback, but that remains to be seen. It could be just a global effect, and then some areas that are out of sync or in the different configuration, they kind of reestablish themselves.
Another question. In the example of fMRI activation, was that the result of normal anisotropy, nuclear radiation inflammation, and activation of the brain immune response?
No, actually, that wasn't. It was simply the blood oxygenation response. So it's the classical fMRI signal that you see in publications that are related to metabolic activation. So it's how much the cortical tissue requires oxygen. The neurovascular properties of the tissue that post activation of the neural activity, there is a drop in oxygenation in those regions. And so it's a kind of a proxy for metabolic neuronal activation in that part of the cortex. So it doesn't have anything to do with inflammation per se.
Are there changes in alpha center frequency correlated with changes in power? And if so, then different cross-frequency coupling would result possible recruiting of different networks. This is from Dr. Gennardi.
I think we looked at the changes in peak alpha frequency. I think there were some smaller effects on that. So usually as alpha increases in power, the central frequency decreases because the higher alpha power is linked to lower arousal. And the central alpha frequency, when it slows, is also linked to lower arousal. But I don't think that those changes in peak alpha frequency were as reliable as the changes in power. So potentially, we know that in PTSD for sure, on the group level, there are differences in central alpha frequency, i.e. PTSD patients display higher peak alpha frequencies, which is consistent with the fact that the brain is hyper-aroused. So potentially another protocol to explore might be to decrease the central alpha frequency in patients with PTSD, or decrease alpha beta power and so on, to see does that also decrease their arousal. We haven't tested that.
The last question from the internet, it's right on, it was the first one, but it's right on point with this alpha frequency. I'm trying to interpret two questions. Donna Creasy asks, why not use peak frequency protocol instead of alpha power down? And then there's this, if you were treating youth with developmental trauma, would you start at P4 instead of PZ with thinking of brain maturity factors?
So the answer to the first question is, yeah, why not try also peak alpha frequency? That could be another study that one could explore. For sure, as I said, there are studies showing the peak alpha frequency being different. But at least in our study, we found that changing alpha power is actually very easy to control, which is one of the pre-requirements of the Neurofeedback studies, that you can, alpha power has a very high signal to noise ratio, I think probably higher than peak alpha frequency, but it could be a similar size of the same coin, or it could be different sides of the same coin. So those, if they are different sides of the same coin, then we would have to explore which one of that, which part of the coin is better, let's say, or has higher clinical impact. But at the moment, we didn't look at peak alpha frequency, but it's certainly an interesting biomarker as well. And then in terms of the second question, why we didn't train at P4 or the PZ, well, I didn't think we found any evidence for asymmetry in alpha power in these patients. So i.e. alpha power being lower in one hemisphere than another. I think it was pretty much symmetric, and decreased symmetrically. So for the moment, we didn't really have an hypothesis on having a more asymmetric protocol, but it could be that in maybe youth, as you mentioned, that there is some asymmetry there. Again, this is one kind of protocol fits all. Maybe in the future, of course, we will need to personalize these protocols based on QEEG for each patient. You know, it is maybe a starting point that if you do see a patient with low alpha power, that could be a starting point. That's kind of in line with this general literature. But of course, if you don't, or there's some other abnormalities, then of course the picture can be much more complicated. And bear in mind that, you know, arousal, hyperarousal, which is the thing that's mostly linked to alpha, isn't the only symptom of PTSD. So remains to be seen also, you know, how the other symptoms are impacted. But we know from the clinical overall score that they improve in this CAPS scale. So we need to see the specificity of this protocol also for dissociative symptoms, reliving of the trauma, flashbacks, and so on. So I think we need to probably run a bigger trial at some point also to have that variance in the data.
Sorry, hi Thomas. Thank you for the presentation. I just wanted to ask you whether you differentiated in any way between your PTSD patients who had very early childhood trauma that's often persistent, particularly if it's emotional abuse that's gone on for years and years and years, and then your PTSD adult patients who've had really severely acute PTSD episodes, because I'm wondering if that makes a bit of a difference. And it also, I think, justification for using PZ as opposed to P4 and P3 is because of that kind of complexity. And PZ, as we all know, is so key in the default mode network, but other networks too.
Yes, yeah, interesting, and thanks for the question. I can't tell who it is speaking, but I detect an English accent. Sorry?
It's Leslie Parkinson, Thomas.
I had my suspicions. I didn't want to jump the gun. Leslie, I send you a big hug from Geneva. I haven't seen you for a long time.
No, thank you, Thomas. Yeah.
It's a pleasure to hear your voice again, and I hope we can touch base in London. But to get to your question, Leslie is actually my old PhD co-sponsor, so I owe a lot of my career to her magnanimity and generosity, so that I started my PhD with her help But anyways, Leslie, I think that's true. That's a very interesting question. I know that in our sample, if you look at the paper, the predominant type of PTSD was childhood trauma related. So
Right.
I think maybe 80% were from that category. Maybe there were a few other sort of adult trauma, but I think mainly Professor Lanus's patients come from that pool. So yeah, we need to also bear in mind that this sample was not as heterogeneous as all of PTSD, especially PTSD people with military trauma and so on. So I don't know if it's specific to PZ. I think we need, again, much bigger samples. Here we're talking about 20 patients, so that's not enough to cluster different types of PTSD, different etiologies, different types of symptoms. We need samples of at least 100, 200, 300 of patients to see, okay, how these different symptoms or different etiologies might be related to the different EEG patterns. So I think that's definitely a lot more work to be done there to personalize, again, the treatment to the type of PTSD.
Thank you, Thomas, and good to see you too.
Yeah, pleasure. See you soon. By the way, I'm coming to London in September. We should meet.
All right, so that concludes the academic sessions in this room today. Please join us tomorrow morning. Breakfast is at 7 a.m. in the vendor hall, which is right next door. And the first session in this room will be at 8 a.m. tomorrow. So now is a great time to grab some lunch in one of the restaurants in the hotel or visit the vendor hall. Make sure to get your ISNR conference passport stamped so that you can be entered in the drawing for Sunday morning. So you have about 2 hours. You have this break in your schedule. After you come back, you'll head upstairs just to the second floor for the conference workshops that begin at 2:45. So, and then after those workshops are over, you are able to visit the poster sessions and the welcome party. So thank you, everyone.